Thank you. I want to follow up on some of Mr. Gardner's questions. First of all, I want to understand this. There has been one person that came to the U.S. and then he infected two healthcare workers in Dallas, correct?
At this point, none of the 48 contacts he had before getting isolated have developed symptoms, and they're mostly well past the maximum incubation period, although not completely out of the woods.
All right. And for everybody on the panel, it's code red. We have had very few, 2 instances of infection here in the United States, but this is such a highly contagious disease that we're on full alert, correct?
It's a disease that has it's a very severe disease. It's not nearly as contagious as some other diseases, but any infection in a healthcare worker is unacceptable.
That's right. And there's an enormous, enormous amount of public concern and apprehension about this. So we appreciate the full-on efforts that you're making. There's been some lessons learned from what happened at Dallas. The hospital's been forthcoming about mistakes that were made. And now what you're telling us is that there has been information provided to all our hospitals in the country about what protocols to follow, correct?
Correct.
Now, just on a practical level, does it really is it feasible that all our hospitals are going to be in a position to provide state-of-the-art treatment, or does it really, as a practical matter, make sense for hospitals to contact you when they have a potential infection, for you to come, and then for us to have centers to which that individual who is infected can be treated?
Every hospital needs to be able to think it may be Ebola, diagnose it, to call us as they do. We've had hundreds of calls, and then we will send a team to determine what is best for that hospital and that patient.
And then what we have also heard, Ms. Schakowsky asked this question, this is absolutely a public health infrastructure issue where it gets out of hand, correct?
Public health measures can control Ebola.
Right. And they have had effective measures in Nigeria where they've been able to contain it, but they have no public health infrastructure in these 3 countries where the epidemic is now getting some headway, correct?
Exactly.
Right. And then in the U.S., of course, we're fortunate to have a pretty good infrastructure, but we do have to have an answer, I think, to this question that is being asked about travel. That is a concern that people have because it is seen as a, quote, easy answer. And I just want to understand what the debate is within the medical community. You know, for a lot of us sitting up here, we're hearing from our constituents. It sounds like something that we can do, and that'll eliminate any possibility of an infection coming here. But that may be a psychological answer, but not necessarily an effective medical answer. All of us have been asking you to give your explanation, and anyone else can come in, as to why, from a medical standpoint, you have concluded that a total travel ban is inappropriate and not effective.
First off, many of the people coming to the U.S. from West Africa are American citizens, American passport holders. So that's one issue just to be aware of.
All right. And then, by the way, I don't have much time, but our healthcare workers, even if there's some risk of infection, if we're going to encourage people to go and do the important work, including our military personnel, we've got to take them back and make sure we can treat them if, in fact, they do get the illness, correct?
People travel, and people will be coming in.
And as I understand, you say there's basically a trade-off. If you have a full-off ban, there's going to be ways around it, and then you're going to lose the benefit of being able to track folks who may be infected, and then that could lead to a greater incidence of outbreak. So it's a trade-off. Is that essentially what's going on?
We're open to any possibility that will increase the safety of Americans.
Right. So are there some midpoints like that in terms of travel restrictions as opposed to a travel ban that may make sense, you in coordination with your colleagues, particularly Mr. Wagner?
We would look at any proposal that would improve the safety of Americans.
All right. This isn't about funding, so I'm not going to ask you because I think we would know what your answers would be. But I just want to share my concern that it was expressed by Ms. Castor. Mr. Chairman, we may want to have a hearing at some point about what is the funding requirements to make certain that the infrastructure this country needs to be in place before something happens is robust, it's strong, we've got people who are trained, they're ready to do the job, and they have everything that they need. So that's not today's hearing, but I think it's a question that we should address because with 20% across-the-board funding in NIH, I find that to be a reckless decision. with 12% at CDC, I think that is definitely the wrong direction. I think this Congress has to revisit our priorities on making certain that we have the public health infrastructure to be prepared to protect the American people.
I think I should say we are planning a second hearing, and in preparation for that, we'll also ask if NIH does have the flexibility now to transfer funds, as well as HHS. We'll move forward on that. Who's next?